Terrific to be here with you all today. It's been fun for me. This is my first time at the CCC conference. As Bruce mentioned, he's a friend. We work together on some innovative projects that are at this intersection between new ways of delivering care and trying to find ways to make that work with all the regulatory and financing policies that are involved. But it's been terrific through him to get to know a number of you. Jamie, the Learning and Action Network, which is doing some tremendous work, and all of the activity around digital health and telemedicine that, as you've heard already this morning, as you know, has the potential to really transform the way healthcare works, making it much more convenient and personalized and also lower cost. And the way that you all are going about doing it is just terrific. I've had a chance already to meet a lot of the innovators here and leaders, people like Mike Ong and his group at UCLA, the CareNection team, a number of people from Austin, Texas, where I grew up, go Austin, and also some other innovators. Is Nick here, by the way? So we've had this way of getting people together, and I just want to thank Nick for my socks this morning. So this is an example of the kind of interaction that takes place at meetings like this one. People who have the same goals in mind, very different perspectives, and don't mind taking a creative approach in order to get there. Now, I come from Washington, D.C. We've got a new program that's working closely with Duke University, and most people, when they think about Washington, they don't think about creative people working together effectively and finding new solutions to problems. So what I'm going to try to do is dispel that notion a bit. There's no question we have some big fundamental political disagreements going on right now about many important aspects of healthcare and health policy, and they will have implications for what you're doing. Elections do matter. But at the same time, the fundamentals in terms of technology development, what people want that are driving a lot of your interests and that help you get up every day and realize how much of a difference you can make, that's having an impact on policy as well. So hopefully by the end of this talk, you'll have some clear ideas about the ways in which the activities that you're supporting could be better supported by feasible steps in places like Washington and state capitals around the world. So we're going to talk about four things in my remaining time with you. First is some of the fundamentals that are driving healthcare policy, and a big clue here is it's the same things that are driving changes in our healthcare system. I want to highlight how important this is to Americans. Health policy and the things that influence the health of individual Americans and their loved ones, probably the number one, if you look back at health policy or public policy for the last 40 years, the number one influence, I'll show you why I think that's true, on what government does. So how you convey having the most impact on better health for people and their loved ones is really important for driving good policy. And there are also very many opportunities to drive better care. I don't think I need to spend much time talking about with this group what those opportunities are, since, again, you're living them every day. But I do want to mention that to put it in context. As I say in Washington around the country, elections do have consequences. There's some fundamental differences between the parties. I'm going to try and play that out a little bit. Bruce asked me before I got here, so you're going to explain Donald Trump's health policy. No, don't expect that to come this morning. I'll try to give you a few insights of how even a Trump victory might likely unfold. I really want to emphasize that there is more bipartisanship than you might think going on in health policy around this country, especially in the issues that you're working on. And I talk a little bit about what those might look like. When people think about health policy, they usually think about regulations, that's the FDA issues that Bruce was alluding to before, and reimbursement, so financing, what gets paid for and what doesn't. With government accounting now for the majority of healthcare payments in the United States, policies matter a lot. But again, there's some opportunities there for real progress to support the kind of care that you want. And I talk about consumer, or as you say, client engagement in financing reform. I think that's something that is underdeveloped. It's clearly underdeveloped in terms of our healthcare system giving clients, people who need services, access to the coordinated set of services that are best for them. I think there's some policy changes that could help support that too. So that's what I'm going to try to cover in the next 40 minutes or so. Sound okay? All right, so let's talk about healthcare fundamentals. Most important, or most visible to the American public, of course, is the breakthroughs in medical technologies that just seem to keep happening steadily. I did my medical training in the early 1990s, and when I was on the wards at Brigham and Women's, we had an awful lot of HIV patients who basically just came in and died. All we could do was offer supportive care, treatments for their opportunistic infections, and anemia and other complications from treatment. That care has been transformed in less than 20 years to a condition that now millions of Americans are living with. We're doing a better job of preventing maternal to fetal transmission. It's been transformed. Cancer care, still a leading cause of death in this country, but 20% population mortality improvements in the last 2 decades. It's not happening across the board, but again, with insights from new ways of treating different kinds of cancer, with a lot more coming, with the genomics revolution in terms of effective targeted therapies, potential for even more in the future. Heart disease, mortality rates are more than 60% down from what they were in the mid-1970s. A lot of that is biomedical knowledge about behavior and risk factors, things like smoking and diet, nutrition, that make a big difference. But it's also things like new drugs to reverse heart attacks and new procedures for patients who are at risk of cardiovascular illnesses. Hepatitis C has been in the news a lot. And right now we're seeing a transformation there as well, from a chronic disease that often led to very unpleasant downstream complications to a condition that can be cured. And there's a lot more coming. Think about just about any other area of medicine, whether it's a life-threatening illness or a condition that affects quality of life, like degenerative joint disease. We're seeing transformations from better devices, better procedures, cell therapies, prevention-oriented treatments that are likely to continue. And that's why some of the biggest political responses and most bipartisanship in Washington is around things like the president's recently announced precision medicine initiative or the cancer moonshot. This is something the American public really believes is worth investing in and want to see more of. The problem with all of this, though, is it's good. Not saying curing disease is a bad thing, but generally it's led to higher costs. And the main reason for it is that people are willing to pay a lot for treatments that help them live longer, help their mother stay around longer, or what have you. There are some savings that are discussed around, when you prevent a heart attack or prevent a patient from dying from lung cancer or prevent the complications of hepatitis C. There are some savings that come downstream in terms of people not going on to develop the complications of those conditions. But we haven't yet figured out how to cure everybody for everything forever. And so what's tended to happen to offset some of those savings, which are definitely definitely important, is more spending on other downstream conditions like chronic neurodegenerative diseases, where the spending has gone way up. But the most important thing I want to emphasize is that the value of these treatments is not so much in preventing healthcare costs downstream, important as that is. The value is in this is what people really want to spend their money on: better, longer lives for themselves and their loved ones. And there have been, and oops, I'm not sure what happened with this slide. There have been I think this one's not gonna come through okay. But there have been a lot of studies by economists. I'll just talk you through this one of how much of an impact better health has had on the economic output of our country. And their conclusion is that with any reasonable valuation of longer life or better quality of life, the healthcare sector has been the most productive in our economy by far, with trillions of dollars in value created. It doesn't show up as GDP. It shows up as the things that people really want besides spending money. More time to spend using those iPads or that nice new drone that you're giving away today, or just more time enjoying the sunsets with your mom. That's really valuable. The challenge that's come along with this, and this is what the slide that didn't go through would show, and I'll make sure that we get it out to you all, is that healthcare spending has become the dominant growth, or really the only area of growth in both federal and state and also local governments, going from about 1% of GDP in the early 1970s, before we had all those cures, to 5% or more of GDP at the federal level on Medicare, Medicaid, and the Affordable Care Act subsidies. So it's 5% of GDP. That's 1 out of every $20 in this country going to my former agency. It's over $1 trillion agency today. And the future projections are for those to go up even more. The consequence of that has been everything else the federal government, state governments have spent money on has had to decline as a share of our nation's total output. And that means things like so-called non-defense discretionary spending have steadily gone down as a part of our national spending. Now that's everything except military spending, which is now only about a third of what we spend for my former agency, CMS, and the healthcare programs that I just described. So we're spending a lot more on these programs, and people are living longer and better, no question, in part as a result of that. But if you think about the other things that really make a difference for this country, things like spending on early childhood education program or assistance programs for low-income families to help them get a leg up or through difficult times, or spending on infrastructure, even spending on R&D, that's all been compressed. And really the story of federal and to a large extent state policy over the last 40 years is that when Americans are asked to make a choice via their representatives between spending more on health programs like the ones I've just described and spending more on anything else, healthcare generally wins. It gets squeezed a little bit, the payment rates get cut in Medicare and Medicaid, but compared to what's happened to the non-defense discretionary programs, spending has gone way down in those other areas. It's built into current legislation that's operating now around the federal budget. You guys may have heard of the so-called sequestration legislation. It builds that in.
I know this is an innovations problem, but
okay, so that's right. That's fine. I can deal with slides that aren't working well, if you all can. So this is part of innovation, right? It's innovation in how I do the presentation. So the politics behind this? Again, how do we achieve both better results, better outcomes for our population, and also recognize that there are many other critical national priorities that we're trying to deal with at the same time? And healthcare has gotten a lot of attention around the election, not nearly as much attention as whether or not Donald Trump uses a full-length mirror, how big Marco Rubio's ears are, but a lot of attention around the debate over the future of Obamacare, the ACA. So this is a fundamental issue about the federal government's role in regulating and subsidizing health insurance markets and coverage. And the reason that it's so important is not just because it's healthcare, it's because of what I told you before. This is where the money's really going. This is probably what happens with health policy in terms of coverage subsidies. Is probably the most important issue in terms of the size of the federal government, size of the state government for that matter, in terms of the major roles for government in terms of influencing individuals' lives in this country. So you can see why that's a big issue. Related to that are issues of price regulation. Should the government come in and do it? Should it be left to private markets, which might create more incentives for innovation? These are areas where the parties, as you know, fundamentally differ. And I think a lot of the supporters of the ACA may have had the idea kind of early on, you probably heard this, that look, let's get this program implemented. Yes, there are going to be some really big bumps and challenges along the way of doing that, but once it is in place, once we get over those initial challenges, just like other federal government expansions in the past, like the Medicare program or Medicaid or Social Security before that, once people start using this program and depending on it, it's going to be hard to go back and change. And no question, since the main part of the ACA was implemented in 2014, the exchange subsidies and the exchanges that are run by the states in some cases and the federal government in most, there's been a huge impact on the uninsured. We've never seen anything like this in trends in this country, going from uninsured rate among the under 65 of close to 18%, 19%, down to under 12%, and even fewer kids today without insurance than ever before. So no question that's important in terms of access to care. It's been particularly important for people with pre-existing conditions, because now they can get access more reliably to health insurance than they could in most states before. It's been particularly important to those with limited means, they'll talk more about in a second. But if you look at the public surveys of this program, it has not had what you saw in some of those other programs before, within a few years of implementation, of a broader recognition or broader support emerging among the public. It's still running about even, negatives a little bit higher than positives actually, among the general public. And that's different from what happened with, say, Medicare in the 1960s, or a program that I was there for implementing, Medicare Part D, the Medicare drug coverage that was enacted in 2004 and started in 2006. I think there's several reasons for that. For those of you who are watching the news this morning, instead of, not out too late last night, there's a new survey released about the public views of this. Part of it seems to be that it's maybe smaller parts of the population impacted. You say, well, this is a big program. I mean, we hear about it in these debates about how fundamentally Obamacare is transforming the country. Well, look at it, it's only about 20 million people out of the entire country of well over 300 million that are getting coverage in this program in one way or another through the Medicaid expansion or the subsidies for the ACA. So that's not that much of the American public that has any direct experience with it or experience through a family member. Contrast that with Medicare, where you may not be on Medicare yourself, but throughout the whole income distribution of the population, people are experiencing it, and especially if you've got a parent, they're probably on it. Also, this program has turned out in implementation, and you can see where this might have come from in design, to be very highly income related. 80% of the beneficiaries in the exchanges get a subsidy, and those subsidies generally run out around 250% of the poverty level, so that's around $55,000 or so for a family of four. It may seem like kind of high, but most Americans in the middle class who feel like they're really struggling with healthcare costs today are probably making $50, $60, $70, $80,000 a year. That's kind of more typical middle class family, or people who think of themselves as middle class. So they're not getting much in the way of subsidies. So what will Republicans do if they get elected and actually had to follow through on their very clear statements for every presidential candidate and every Republican running for Congress this year, that they would repeal and replace the Affordable Care Act? Well, it's sort of a lot easier to criticize when you're not in the majority than it is to come up with a alternative plan that can get broad support and get through. So this is not by any means automatic, but I wanted to highlight there are three different kinds of Republican plans out there. The Republicans are definitely not unified on this set of issues. And kind of the more conservative end of the party, the Tea Party end, there's a group called America Next, which is the part of the Republican caucus in Washington that kind of represents the Tea Party. And they would replace this entire program, and even go further, replace existing Medicaid programs with a different approach to healthcare, reflecting their different view of what the federal government's role should be. They would give people a standard deduction for health insurance that would replace all the subsidies for coverage that you get under the ACA, the premium subsidies and for lower-income people to help with low-income assistance. They keep the popular parts of the law. There are two parts of this law that are very popular and do poll well. That's the guaranteed issue and community rating, and you being able to keep your kids on your insurance until they're over 26. So they keep those pieces in place, but you only would be able to get the guaranteed issue if you were continuously enrolled in insurance, and there wouldn't be as much protection for community rating as is under the law today. Medicaid would be replaced by so-called block grants or state grants for assisting individuals with low incomes to limit the cost growth in that program, and they would argue to give the states more flexibility and ability and incentives to control the overall cost of those programs. And then the more moderate parts of the Republican Party, you see proposals that look more like what Democrats have supported with the ACA. So these programs would keep a tax credit, just as is under the law now. That's very important for people with low incomes, because if you don't have any tax liability, a deduction doesn't do anything for you to help with costs. So that's an important difference from the more conservative Republican proposals. In fact, the more liberal or centrist Republican proposals, like Elizabeth Burr, Hatch, Upton, Patient Care Act, would keep kind of an income-related credit for insurance. The amount in most of these proposals are pegged about an average of $2,000 per individual. Why? Because that's what people get now in their subsidies for employer-provided coverage. They want to make it on par with that. But what you can see with this kind of proposal is that would be a lot less of an amount of subsidy for lower income families, those two, the lowest 20%, that do very well under the Affordable Care Act in terms of new financial help. So much less help there. It would be more even out through the higher part of the income distribution. For example, in that 2017 action plan, which is what's similar to what Marco Rubio and other Republican candidates, Jeb Bush, when he was still in the race, had supported about $2,000 per person, but flat, not changing with income. So that means actually does more for middle class above $50,000 in income than the current proposals in the ACA. So this is a very different plan. And then also going along with this, I think the Republicans would feel like they've got a mandate to do something fundamentally different in Medicaid, because they've been running on that. Not just Medicaid expansions, which they're all for repealing, but Medicaid overall. So moving towards more flexibility and more state control in how those programs are developed. So what would actually happen? Well, if the Republicans do manage to win the presidency, to pull that out and keep control in the Senate, they can actually pass most of this, not all of it, but most of it through what's called reconciliation legislation. So this is where you only need 50 plus the Senate speakers vote in order to pass the law. They're expected to keep control of the House regardless of what else happens in this very unusual election season. And so they could pass most of these proposals out. That doesn't mean it would actually happen. There would be a lot of criticism from opponents of changing the current law. So you probably will end up with something that's a bit of a controversy, but I would definitely expect less generous subsidies, especially at the low end for insurance, more flexibility in how people get coverage, replacing the current mandate to buy health insurance and the tax penalty for not doing so with something like a guaranteed issue and community rating requirement that you got if you kept continuously enrolled in coverage. So it's more of a personal responsibility version of trying to make health insurance markets work. How does this work? Why would they think this might work? Well, this is actually what happens in Medicare today. So for Medicare Part B and Medicare Part D, those are voluntary programs. There's no penalty that says that you have to pay if you don't enroll. But seniors overwhelmingly enroll because if they can't get coverage, if they don't get coverage when they're first eligible, they pay more later every single year. There's kind of an actuarial adjustment built in. So the Republicans are thinking of something similar to that for health insurance, and then big changes, probably a lot more state flexibility in how states do coverage. And by the way, this is something that Democratic governors are also supporting. So going back to my earlier slide, the main source of budget increases at the state level today is Medicaid and coverage for health insurance coverage for state workers and state retirees. And because of those increasing cost pressures, governors are having a lot harder time continuing to pay for K-12 education, preschool programs, low-income assistance programs, virtually every other state priority. So I think that is likely to change. If the Democrats stay in control, expect, you've heard from Sanders, Medicare for all. Very hard to see how something that big and different could get through a Republican House of Representatives. President nominee or presidential candidate, I don't want to prejudge this, presidential candidate Hillary Clinton has talked about expanding the Affordable Care Act, mainly to go after those middle income voters who are not seeing much benefit from the ACA as it exists today. So somewhat bigger subsidies, higher up the income distribution, but keeping the same basic structure in place there as well. Hard to see, though, big changes coming if the Republicans remain in control of at least one house in Congress. So those are the partisan parts of health care reform. I want to spend my last few minutes before we open this up for discussion going briefly through some bipartisan issues. I'm going to have a lot of slides here. I'm not going to go through all of them now, but I'm going to make them available to you all afterwards. I just want to get across a few basic ideas. There is, importantly, a lot of bipartisanship in Congress right now and in state legislatures around some things I think can have a very big impact, especially on the value of health care and the degree to which the innovations that you all are working on can make a difference in health care delivery, can actually be adopted and start more widely impacting patient lives. So this is especially around issues of payments and benefit reforms, changing the way that we pay for health care to get higher value. This is really important to try to develop these ideas, because the other alternative, if costs keep coming up and keep going up, and other programs get squeezed, the other place where Republicans and Democrats do seem to be able to get together is to continue to squeeze down the payment rates for healthcare providers, as you heard from Jamie, asking you to do more with less, rather than asking you and supporting you in doing something fundamentally different that gets to better results. So it's more with less versus doing it better, changing the way that healthcare works. So we've talked about some of the things that are driving healthcare costs and also the value of care. Particularly, I emphasized these new effective treatments for unmet health needs, which are making a difference. They're often overused. Perhaps Bruce was talking about Da Vinci robotics. That's something that does get reimbursed a lot in our healthcare system today, and probably isn't adding as much to value as some of these other things could. Where you all really come in, I think, is a lot of the stuff that's listed under this potentially cost decrease. And this is the kind of innovation that's dominant in many other industries. It hasn't been dominant in healthcare. Things like better targeting the use of medical technologies to patients who actually benefit. So maybe that Da Vinci robot is good for certain cases. Let's make sure we have the data and the decision support systems to get it to the patients who are really going to benefit. And especially, as you're going to talk about much more today and tomorrow, and therefore going to skip over here, telemedicine, remote monitoring, things that bring, just like every other sector of the economy, is moving towards more personalization and convenience in the home. Healthcare needs to do the same thing, and you all are going to help us get there. Shifting sites of care from the hospital to the doctor's office or out into the community, or again, even to home-based services. Better care coordination, the number one complaint that Americans have about their healthcare system. Most Americans still today, despite everything that's wrong with their healthcare system, feel pretty good about the access to technology and about the quality of care of their individual doctors. They feel terrible about the lack of coordination of services, the duplication, the inconvenience, the frustration, just getting the right combination of treatments for their needs. And the last thing, where I know the land has been very active, is around supplementing traditional health care with additional help, language help, other help for people who need it, and ways of accessing social and community services, changing the way that we deliver health care to be, again, more about helping the patient with their needs, whether it's palliative care or home-based services that can keep them out of the emergency room or their hospital, whatever it is that they need, not just thinking about traditional ways of delivering care. The problem, and it's a brief digression from my experience at CMS, one of my first meetings at CMS was with a group of CEOs from some innovative provider-led organizations that were trying to do all of these things. These were from places like Geisinger Clinic in Pennsylvania, and some of Palo Alto Medical Foundation, some organizations from here out west, who were talking about in Medicare, for Medicare beneficiaries, they were trying to do all of these things, using team-based approaches of care, pharmacists, nurses, helping patients adhere to medications, answering patients' emails, starting to use telemedicine. This was a decade ago. This is not as far along as we are today. And they actually had data showing that these steps, used effectively, targeted the right patients, were leading to better results for their patients. Either their diabetes was under better control, they were having fewer admissions to the hospital with preventable complications, and Medicare was saving money as a result of these changes. But what they pointed out was that, Mark, we can't keep doing these things because we are getting killed financially in implementing them. First of all, almost none of these things on this list are reimbursed under traditional fee-for-service medicine or fee-for-service Medicaid programs or many other traditional insurance plans. And second, to the extent that these things work, the doctors were billing less for the stuff that they could bill for under Medicare. They're having fewer visits in the emergency room and hospital attending, and even fewer doctor's office visits because the stuff was working. So that is not a financially sustainable model. And so a lot of the goals in healthcare reform are really about moving from doctors and hospitals and people like you who are working with them, trying to do more with less, trying to build in some effort or free up a few resources out of an increasingly tightly financed healthcare system to do these kinds of things, and instead move to healthcare financing that's done in a way that makes support for these innovative, high-value approaches to care much more automatic, much more aligned with the goals of improving healthcare delivery. So that takes some changes in payment. And again, I think some of these slides are not going to come across well. What's on this slide is the LAN. This is not the language access network version of the LAN. This just shows you that healthcare is all about acronyms, and every acronym gets used at least 2 or 3 times. This one is for the Healthcare Payment Learning and Action Network, which is a collaborative effort that CMS has set up with many private healthcare organizations, plans, provider groups, and the like to try to accelerate movement to these new kinds of financing models that do a better job of supporting improvements in care. The main goal here is to move to, let me see if I can find a slide that's working pretty well here, moving from payments for specific services to payments that really are more about the person. I know many of you are familiar with episode-based payment reform. CMS is now trying to do more of these. Many private plans and states are even further ahead. Instead of paying for specific services, this is a payment that goes to a group of providers collectively that are accountable, that are taking on some overall accountability for the patient to try to get to better outcomes and lower costs, where the payments are not based on volume and intensity of services, but based on did these providers working together achieve what the patient really wanted. This depends on how well you can measure things like clinical outcomes for care that matter, or patient-reported outcomes are an increasingly important part of this. It means new ways of doing business for healthcare providers, because they're starting to take on some financial risk, or some risk not just for, hey, did that patient, when they came into my office today, get this particular set of services, check, send in the bill to Medicare, but rather, did this patient who has diabetes or risk factors for diabetes actually get better disease control? Whether or not they came into our office or not, we care about as a result. So it's a new kind of financial risk, but the flip side of that is they get more flexibility in using the resources, the tremendous resources that we're spending in our healthcare system, to put it towards what really matters for that patient, to get the best outcome at the lowest cost. Some of these models are at the episode level, and there are a number of organizations that are doing kind of whole patient accountability. Many of you have heard of accountable care organizations, which are a form of doing this. So there's one that came through. So this looks pretty complicated. Let me just real quickly tell you what's going on here in terms of thinking about. So this is bipartisan support now on where our healthcare payment systems are going. Traditionally, we paid in this country fee-for-service, so that's that Category 1, without really much attention at all to quality. The last decade and a half saw a lot of efforts around what this framework calls Category 2, fee-for-service with links to quality and value. So think about like the way that Medicare and many plans pay today, where it's still fee-for-service. You get a little bit of an adjustment up or down based on whether certain quality measures are met, like so-called meaningful use payments, or the physician quality reporting system in Medicare. For those of you who don't think there's bipartisanship in healthcare, remember last spring, Congress came together and passed with almost 400 votes the biggest Medicare reform legislation since the MMA of 2004 in what's called MACRA, which was Medicare Access to Care, and payment reform legislation that sets up a new payment system for all physicians in Medicare that's essentially this Category 2 on steroids. So by 2019, CMS is supposed to implement a system called MIPS, the Medicare Incentive Payment System, that can adjust payments up or down up to 14 and increasing to 18% for individual physicians off the codes that they bill for, based on the kinds of quality measures that people think should be part of considerations in healthcare delivery. Things like whether or not you're using health IT effectively. Things like whether or not your patient's getting high-value care. The challenge of this approach is that it's still based on fee-for-service. So if you're trying to do things like telemedicine or digital health, where your patients don't come into your office very much or at all, you've still got this problem of having to bill more for services that are actually covered in Medicare. You know, there's some efforts by many telemedicine advocates to try to expand the scope of telemedicine services that can be charged. It's only a tiny part of billing. So the point is that this is still not very far away from the traditional way of paying in healthcare. These other treatment models, these other payment models, I should say, I was talking about, the accountable care at the episode level, the person level, are what's in category 3 and 4 on this model. And one of the things that legislation last year also enacted is it gives healthcare providers an out. So if they don't want to report on 80 different measures of quality and have to bill in these very detailed, complex ways in Medicare, they can move to a so-called alternative payment model in which they're paid in part or maybe in full based on things like how well their patients are doing for episodes of care like cancer care or heart disease care or procedure performance or at the overall patient level like in an ACO. Category 3 is basically a version of sort of a parallel track version, so that's what we're seeing a lot of today, the so-called Medicare Shared Savings Program. The providers in that still get their fee-for-service payments, but in addition, Medicare set up an overall benchmark for spending at the person level and some overall population level performance measures and if the providers can meet those benchmarks, they get additional payments. So there's at least a pathway. If they're taking steps like investing in digital health or telemedicine that's poorly reimbursed today, and it actually has an impact on reducing overall spending for beneficiaries and improving outcomes, there's the start of a business model for getting there. The problem with that approach for many healthcare providers is it doesn't really do very much, doesn't perhaps do enough to get away from the current system. So I'm going to do contrast of two kinds of organizations that are in this Medicare Shared Savings Program today. One is a hospital physician system. So there are many ACOs now that represent big hospital systems. Duke is a good example of this, my current employer. And this is not going to be a compliment, but they're getting their hearts in the right place. They're trying to get there. So they're participating in the Medicare Shared Savings Program, and they're actually doing some things that are saving money. So they made some investments around congestive heart failure patients, diabetes patients that are starting to pay off in terms of keeping those patients out of the hospital and out of the doctor's office. The problem is, since they're a big integrated system or a big consolidated system, they get the shared savings. They get some of the shared savings from keeping those costs down, but they also lose the net revenues from what those procedures would have enabled them to bill for. And in a lot of cases, these are pretty high margin elective procedures and things like that. So you can see that this is a bit of a shift. It's better than not being paid at all for changing care, but it's still conflicted kind of incentives and not a very strong decision model. Some of the most successful programs in the Medicare, the most successful organizations in the Medicare ACO program to date, and we're now 3 years in, have been small physician groups that don't involve hospitals at all. I'll give you one of my favorite examples. My friend Jose Pena, the doctor in McClellan, South Texas. Some of you may remember Atul Gawan's article about what was wrong with American healthcare in the New Yorker back in 2009. Ground zero in that article was McClellan, Texas, where Medicare beneficiaries cost about $15,000 each, about twice the national average. Very high rates of uncontrolled chronic diseases, very high rates of hospitalizations and complications for procedures of those conditions, lots of use of post-acute care, very high expenditures and poor health outcomes as a result. They came up with an Excel spreadsheet that listed all their patients with diabetes and some other high-risk conditions. How do they know which ones? They just talk to each other, and they know their patients. They made a list of all the patients they want to do more active outreach to. Their big investment with their ACO was a couple of additional staff people, one with nursing training, one with just more of a community health type background to help make sure they reached out to all these patients, checked off all the evidence-based treatments that they should be getting, and help make sure they're complying with their medications. They couldn't get their electronic records even among these three offices to talk to each other. They hired, I think, a part-time college student to extract out of those records just some basic core information they needed to fill out their Excel spreadsheet, and that was the plan. That combined with being a little bit selective in which specialists that they referred to, got some data from Medicare on which ones seem to be doing better in terms of keeping the patients out of the hospital, a little bit of care with which post-acute care providers they referred to. They've achieved from diabetes control rates of about 50%. They've gone to 80% in 3 years. They've made about, this past year, I think it was over $1 million in savings per physician in that group. If you think about it, you don't have to prevent prevent very many hospitalizations, to double, triple, quadruple the income for a primary care physician who's willing to take on this kind of new approach to accountable care for patients. And now they've actually got the money to invest in some systems to harmonize their electronic records. It'd be nice if the electronic records were more harmonized to begin with, but this is a step towards getting there. So they're making real progress, and they're doing it under this Category 3 model. And the reason is that they don't, if they save money on preventing a hospitalization, that goes straight back to the organization. It all comes to help them sustain this program and support revenues in their practice. There's no offsetting within their organization loss of specialty practice revenues. So I think for the more integrated systems, for them to really do well in terms of delivering fundamentally different approaches to personalized care, they're going to have to move on into Category 4, where basically the idea is to get rid of fee-for-service to a much larger degree and have payments based more entirely on things like per member per month, adjusted for quality and performance outcomes, rather than the volume and intensity of traditional services. And there's some healthcare organizations that are starting to do it. I think we mentioned Alignment Healthcare earlier as one. I think many of you all in this room may be working with them. But this is very hard. So I've talked a little bit about this slide. To do this successfully as a healthcare organization, you pretty much have to rewrite the way that you're running your organization. It's a different culture. It's not about doing procedures and not about patient throughput. It's about really focusing on what matters for patients. Culture is hugely important. The organizations have been successful so far in these efforts. It's a different kind of IT infrastructure and data analytics. Most organizations, even the big ones, don't know what happens to their patients after they leave their hospital or the health system and get out of their own EHR. It's about taking on new kinds of financial risk. Healthcare organizations take on financial risk every day to day. Every time you spend an extra 10 minutes with a patient or you answer an email, chances are you're not being reimbursed for that kind of service in your traditional fee-for-service payment plan, but you understand those risks, you're kind of used to them, so you build in those known risks into your financial modeling. You do much more of that to make these kinds of systems work, and you actually need to redesign care in an effective way. The organizations, like I said, that have been most successful so far are not the ones that made huge investments in restructuring their entire IT systems or huge disruptions in their practice structures, but took some clear, identifiable, limited number of steps. They were very confident were going to have an impact on costs and outcomes for at least some part of their patients, and they build on that over time. It's a continuous improvement approach. Now, I was going to talk about Medicare Part D, but the slides aren't coming through well there either. The main point from that was that I talked a lot about provider payment reform. If you really want to make this stuff work, my experience from Part D was that getting patients, clients, consumers more engaged, not in just like giving them a check and a phone book and saying, figure out what's best for you, but giving them a chance to share in the savings. So if you use one of these ACO providers or a specialty oncology group that's really good at getting good outcomes at a much lower cost, why can't you keep those savings? Why should they just go be shared with the doctors alone? Things like that can get consumers or patients much more effectively engaged. And the patients who I think would benefit the most are not the healthy patients, but the ones with the serious chronic diseases where the patients know best what they don't want and need. They're not getting it in the current healthcare system, and there are huge opportunities for reducing costs and improving outcomes for those patients. Thanks very much for the opportunity to get through this with you today, and I'm sorry about the lack of slides, but I'll try to make those available to you afterwards. Thanks very much for listening.